Great. All right. Good afternoon, everybody. Thank you so much for coming out today to our CMDA meeting. This will be the last meeting of the year. We're really grateful for all of you, and we're especially grateful for Dr. Barrows giving up some of his precious time and being willing to speak to us. My name is Hawken Nelson. I'm a second-year medical student at the University of Cincinnati. And here we have Lydia, as well as some of the other student leaders of CMDA here. But I'm going to introduce to you Dr. Barrows, who we're really privileged to have today. He has a DO from the the Des Moines College of Osteopathic Medicine. Did I get that right? And he trained in OBGYN in Columbus and has practiced in Ohio. And more recently, he's been with the CMDA in the executive leadership team. And he has spent, I think, about 15 years teaching and advocating for those who are suffering in human trafficking. So I'm just really excited to hear from you, Dr. Barrows. And I think you have a lot of experience and have publications as well in this important field. So I think it'll be a really good discussion. Yeah, so without further ado, Dr. Barrows.
Thank you. Is it Hakon?
It's Hawken.
Hawken. Okay. Yes. Thank you, Hawken. I'm going to share my screen, and I'm glad to be with all of you. And actually, I'm looking forward to interacting a lot with you because in my role in CMDA, I've been in this role since the 1st of April. I have a real heart for students, the student ministry, and my concern and from a bioethical perspective as well in terms of right of conscience and things like that going forward. I know that's not our topic for today, but if we have some time at the end, I'd love to hear your perspective on how things are going for you all, and because I don't get the opportunity to interact with a lot of students. So that was one reason I took the opportunity to be with you today. But I'm happy to present on human trafficking. As Hawkins said, I have been in it for, I think the Lord called me into it in about 2004. So in training healthcare professionals, and I don't even want to think how old all of you were at that time. That just makes me feel a lot older. But let me share my screen, see how this works. And then, can you see my screen?
Yes.
Yes, we can.
And then I may be messing things up because I'm going to go to the slideshow. I don't know what's going to happen with that. Do you see the slideshow now?
No, we're just seeing your email.
I was afraid of that. I think I might be able to swap displays. That still isn't right, is it?
No, right now it's showing presenter view.
Yes, but it's not really the major. Let me try that again. There we go.
Perfect.
Okay. All right. So the overall topic is just going to be not just human trafficking, but the intersection of human trafficking and healthcare. And I hope you will see it's a very important intersection. These are my educational objectives. I know this isn't for any formal educational activity, but I want you to, at the end, to be able to articulate the scope and presentation to some degree of trafficking, identify indicators that are within healthcare among patients. We'll talk about barriers within healthcare that keep us from recognizing victims of trafficking, and then recognize the importance of protocol development. That's my 4 different goals for all of you today. And as I said, I want this to be as interactive as possible. And so I don't want to put you on the spot. I'm kind of curious how much you might know about trafficking. So anybody that can give me just a very general definition of trafficking, even if not, what are some of the components of trafficking that are necessary to call something trafficking? Anybody have any ideas?
I mean, I would say exploitative labor. If someone is being exploited in their labor.
That's exactly the word I was looking for. Exploitation. That is the key word in trafficking. You can't have trafficking unless you have some form of exploitation. You mentioned labor. We'll talk a little bit more about the subtypes. So here is my general, this is a non-legal, I'll get into the legal definition in a minute, but this is my non-legal definition. And that is human trafficking is whenever one person exploits another for personal or financial gain. Now, obviously you can understand the financial gain, but you might say, well, what do you mean by personal? And the type of trafficking I have in mind there is a domestic servant. I won't have a lot of time to get into that, but that's a common form of international trafficking where individuals may come from another country and they go back to that country and they bring someone back and they use them as a household slave. And so they're not getting financial gain from that person, but they are exploiting them. They're getting a personal gain. And that's really mainly what I have in mind. So that's the key, just a very general definition that I would encourage you to kind of remember. When we talk about the legal definition, I'm going to be using the federal legislation that was passed in 2000. And it's called the Trafficking Victims Protection Act, or we call it the TVPA. And prior to that, we had no statutes in our federal legislation or in any of our states, by the way, that dealt specifically with human trafficking. My understanding is that prior to this, most of the statutes used were like kidnapping, if they had something along the lines of trafficking. So this was brand new and revolutionary legislation in 2000. And when Congress is creating new legislation for criminal activity, they craft it in the way of defining what it takes for a federal prosecutor to prosecute somebody for that particular criminal activity. So when it came to human trafficking, they decided that there were 3 necessary components to be convicted of human trafficking. And you can see the list there, a list of certain actions, and the original legislation had just 5: recruiting, harboring, transporting, providing, and obtaining. And it's interesting that when you have new legislation, a lot of times it needs to be updated because it doesn't quite get to what Congress wants to get to. So the word obtaining is obviously a very general word. And so a lot of federal attorneys, US attorneys around the country, were wondering, after this was passed in 2000, does obtaining mean buying a woman, for instance, in sex that happens to be involved in sex trafficking? And they were unsure because the legislation was unclear. So it took 15 years, but in 2015, Congress passed an additional piece of legislation called the Justice for Victims of Trafficking Act, and it clarified this, and it added patronizing and soliciting. And this is critical because normally the penalty for purchasing a woman that's in prostitution might be a misdemeanor. But putting it in this category here, as someone is purchasing a woman for a sexual act and knows that she is being trafficked, that person can actually be prosecuted as a trafficker. And therefore, they can get up to 30 years in prison. This is a huge change. So it's an additional way for prosecutors to go after those that take advantage of these victims. So the first category is that the prosecutor has to prove that the person engaged in one of those activities. They don't have to engage in all of them, just one of those actions. The second is they had to show that they used either force, fraud, or coercion. And the reason for that is they had to show somehow that the trafficker overcomes the consent or the forces the person into that particular act. Otherwise, they would be complicit. So to do that, they have to show either that they forced them into the activity, they used fraud and lied to them, or they used coercion and threatened them in some way, either them or their family. So that's the second category. And then the third category was placing the person into either some form of sexual exploitation or labor exploitation. So if a federal prosecutor found somebody and it could prove that they transported that person over state lines by lying to them and then place them into sexual exploitation, that person can be convicted of human trafficking. Okay? That's the legal definition. Now, at the same time, we've also defined what is a victim of human trafficking. A victim of human trafficking is anybody that has had those actions done to them through force, fraud, or coercion, and then they've been placed into sexual or labor exploitation. So that's the legal definition. Now, there's one huge exception, and that is dealing with minors under the age of 18. Because when Congress was passing this, they asked themselves, when it came to this proving force, fraud, or coercion, again, the necessity for that was to show that you overcome the consent of the person. But Congress took a step back and said, wait a minute, do we even believe that someone under the age of 18 can actually give consent to commercial sex? And they had a long discussion, and they fortunately came down with the final conclusion that no, we do not believe that a minor can even give consent to commercial sex. Therefore, there's no reason to prove force, fraud, or coercion. So they removed that requirement. Now, this has to do only with sexual exploitation, because we do believe that a minor, a 16-year-old, can give consent to working. And so when you're dealing with labor trafficking, there is still the necessity to prove force, fraud, or coercion, but not with sexual exploitation. And so this is the federal law, okay? That's at the federal level. It doesn't really deal much with the state level, but most states have then, since 2000, crafted their own state laws that follow this fairly carefully. In Ohio, though, since we're talking about Ohio, we are one of the few states, in fact, the last I knew, the only state that does differ in a very important way. Our state law is crafted such that a 16 and 17-year-old, the prosecutor may have to prove that they were forced or used force, fraud, or coercion, because the way our law is written, it depends on the relationship of the trafficker to the 16 or 17-year-old. And I don't want to get too much into the weeds here, but I'm happy to answer any questions. So basically in Ohio, anyone under age 16 that's involved in sexual exploitation, there's no need to prove force, fraud, or coercion. But 16 and 17-year-olds, because we have certain state legislators that believe that a 16 and 17-year-old can actually give consent to commercial sex, they crafted the law differently. And if the relationship between the trafficker and the minor does not have inherent authority built into that, and by that I mean, for instance, is not a parent or a relative or a teacher or a coach, then the prosecutor has to prove force, fraud, or coercion was used. So I'm going to take a minute. That's a little complicated. I want to make sure that there's a basic understanding among all of you, and let you ask any questions about the federal law or the Ohio exemption. Any questions on that? Okay. Well, I want to hear then, just give me round figures. How many people do you think are being trafficked here in the United States? Just in a magnitude level. Are we talking thousands, tens of thousands? What do you think?
2 million.
2 million. Okay. Any other thoughts?
I'm thinking like maybe thousands. That's my guess.
Okay. Well, it's in between. It's not quite millions, but it's more than thousands. So let me talk about the data that's out there. And I need to preface by saying that the data, I mean, asking how many human trafficking victims is very similar to asking how many drug traffickers are there in Ohio. Nobody really knows that. It's a hidden activity. It's very difficult to study. We do get an idea of the number of people that are drug addicted because they seek therapy, but it's very, very hard to study this. But In 2017, the International Labor Organization, along with another nonprofit called the Walk Free Foundation, which is based out of Australia, they went to various regions of the world and they did an analysis and they came up with a prevalence rate of trafficking in various regions of the world. And then they added up all the population, and you can see the number on the slide. Over 40 million people worldwide are enslaved, and they include forced marriage, which has about a third of those people that are enslaved worldwide. Now, we have some forced marriage in the United States, but not nearly what we see in Asia, Sub-Saharan Africa, and other places. So I'm not going to talk a lot about that. But when we look then at just those that are in some form of forced labor, which includes sexual exploitation, we can find that there's actually about 25 million people worldwide. And if you look at the graph you see now, you see that worldwide, the most common form of trafficking is labor trafficking. But that's not the case in the United States. In the United States, it's a form of sex trafficking. So, and worldwide, sex trafficking is about 1/4 of the forced labor. And then when we look at the gender, you can imagine it's more females than males. And when we look at the age, it's about 1 in 4 are minors around the world. So minors defined as anyone under the age of 18. So this is kind of a very broad stroke of what it looks like worldwide. Now, the prevalence rate they came up with for the United States or North America is the lowest prevalence rate of anywhere in the world, and it's 1.3 per 1,000 population. And so you can see that you do the math with our population of about 323 million, means that we have just under 500,000 victims of trafficking here in the United States. So no, it's not 2 million, but it's a lot more than thousands. It's hundreds of thousands. And I think as far as we can tell, this is fairly close, and it includes all types of trafficking. It includes the vast majority of prostitution that occurs in the United States, because a lot of it, it does really fall into the category, a lot of prostitution, even of adults, falls into the category of sex trafficking. So here's my next question, and this is a confusion for a lot of people. Can anybody explain how human trafficking and human smuggling are different, or are they the same?
This is more of a question. So, human trafficking, does that just imply that that is against the will of the individual, whereas human smuggling could be like transporting someone, but that could be in accordance with their will. So, transporting someone across a border, is that the difference? That's just a question.
No, Jenna, I think you're exactly right. It's very confusing, and this is how I divide it out, but it is, you're exactly right in that it has to do with the will of the person. So human smuggling is a crime against a country's border, and it always involves an illegal crossing of a border. And once that border is crossed, obviously, the key is that person is able to live the way they want to live. So if they've come from Mexico or Central America and they get into the United States and then they're able to do what they want to do, that's human smuggling. Transnational human trafficking is a crime against the person. Now, here's where it gets confusing. Trafficking can start out as human smuggling, but then when they get into the United States, they aren't able to do what they want to do, and then they get placed into some form of exploitation, either labor or sexual exploitation. So that becomes human trafficking. So the way to determine the difference, you're exactly right, is what is the person have freedom to do what they want to do once they've crossed that border. If they do, it's smuggling. If they don't, it's human trafficking. So we often hear about sex trafficking, but are there other types of human trafficking? And I just go ahead and say we've talked about both sexual exploitation and labor exploitation. And since exploitation is the key word in trafficking, I just substitute sex trafficking and labor trafficking. And there are a couple of different other subtypes, and that is there's trafficking of international victims into the United States, as we just talked about, but there's also trafficking of US citizens. And so that means that we really have 4 subtypes of trafficking here in the US. We have international sex trafficking, international labor trafficking. We have domestic sex trafficking and domestic labor trafficking. Now, why is that so important to understand? You would think, well, international sex trafficking is probably exactly like domestic sex trafficking. No, it's not. They're very, very different. And international labor trafficking looks very different than domestic labor trafficking. So my question to you is, of those 4 categories, what do you think, and I've already given a clue, what do you think is the most common form of trafficking in the United States?
Domestic sex trafficking.
That's right. You got it. And so because of the way the law is set up, we can also divide it into sex trafficking of adults and minors, and I've listed the terms that are also used. My favorite is child sex trafficking. Domestic minor sex trafficking is a little bit more formal and technical. An older term is commercial sexual exploitation of children, or CSEC. Typically, when we see the term CSEC used, we're talking commonly about child pornography, which is included in this, but child sex trafficking tends to focus more on the prostitution side of this. And by the way, just while I'm thinking about it, I did have the honor of starting a home here in Ohio. It's called Grace Haven. I started it back in 2008. And it's the only, well, there's now 2 homes, I should say. But it was one of the first homes started in Ohio that was specifically designed to rehabilitate kids under the age of 18 who were trafficked into commercial sex, which is altogether way too common here in Ohio. And so that home is now located in Columbus, still open and serving kids. I do want to point out, though, that there are rare types of trafficking, like organ trafficking, where they will take and kidnap individuals, most commonly for kidneys, and put them to sleep and literally steal a kidney from their body. That is happening. It's very hard to follow it and very hard to keep track of it. And there is, as I mentioned, some trafficking in brides. I don't think it's all that common here in the US, not nearly as common as in other places. So any thoughts? What type of forced labor are there in the United States?
I would guess like agricultural.
That's one. And we had a big case up in central Ohio around Marion, where they were trafficking kids from Guatemala into to work in a chicken farm in just north of Marion, just outside of the city there in a rural part of the state. So definitely agricultural and farm. Any other thoughts? Well, I will say that the only form of domestic labor trafficking is that we found is traveling door-to-door sales. And as you can imagine, it's more difficult to enslave a US citizen in labor because they're going to have a lot of ways to get away. They typically will have friends they can get in contact with. So putting a US citizen into some form of forced labor is difficult, but they do have instances where college kids that don't have much family, maybe they were adopted out or abandoned, so they don't have any way to make money, they don't have a support system, but they need to get some kind of income so they can go back to school. During the summer, they can be recruited by these door-to-door salespeople, and they have to meet a certain quota in order to get fed, in order to get a hotel room, and they will put them out typically in the West and very rural areas of the United States where they don't have a cell phone and they don't have ways of getting in touch with people. So we have instances of that in terms of domestic US citizens. When we move to the international side, it's a lot easier to keep someone that's from another country under your control because they've got language barriers. They don't know anybody in the United States. They don't really understand that this is illegal. And so any kind of unskilled labor can be used with these victims. So as I've mentioned already, domestic servants, factories, janitorial jobs, construction sites, restaurants, hotels, and we've already talked about farm work. So it's really fairly broad, and it really is literally around us at all times. We may not even know it. One story that I often tell is that back in, I think it was 2008, in September, when I was starting Grace Haven, we had a fundraiser down in a hotel in Columbus. And during the day, we had our first human trafficking conference in the state. It was in September of 2008. And so it was at a particular hotel. And all day long, we were talking about trafficking, just like I'm doing now, saying how it's all around us. 2 years after that, we found out that there actually was a trafficking ring that was bringing women from Ukraine into that hotel to work as maids to clean the rooms. So while we were doing our conference on the ground floor of the hotel, we literally had victims of trafficking right above us. So you never know where they can be. So who are the most vulnerable, do you think, that to be caught up into trafficking in terms of age and sex? Thoughts? Let's think first of all in international.
I would think women, and maybe around starting around the age of maybe 13, 14.
Okay. Other thoughts? Well, here are the vulnerabilities for international, and women are more likely. It's not internationally, it's not the younger girls. We'll talk about domestic here in a minute. But I would just want you to understand and go away from this. And one of the few things hopefully you'll remember is that the major vulnerability internationally is poverty. In other words, why would someone want to leave their home where they have family, where they have friends, where they have connections, and go to a strange other country? What is it that's going to drive them out into that? And of course, the biggest thing is poverty. Next, as you can see, is family instability. There's a lot of countries that there's conflict within the country, or there's revolutions. And so the person may not feel safe. And so that's why they put themselves at risk of being exploited. There are a lot of people that come into this country and they know that these types of things happen, but they still want to take their chances because of these vulnerabilities. So that's the international side. When we move into the US and look at what is it that puts a US citizen at risk, it's not poverty, it's abuse, especially when we talk about child sex trafficking. Almost all of the girls that we had when I was associated with Grace Haven, I'm no longer working with them because of my work with CMDA, but almost all the girls we had a background of being sexually, physically, or emotionally abused in the home as they were growing up. So that's the number one vulnerability for US citizens. In addition is family instability. And then ironically, in major cities, even in, for instance, in Cincinnati, there are areas of Cincinnati where kids are living, where they are used to seeing women walking the street in prostitution, and they understand what's happening. So there are neighborhoods where it becomes normalized. And so that it creates a vulnerability for them to also be caught up into it. So I want to begin to transition now into how does this apply to us in the healthcare profession? And basically, between 50 and 88% of human trafficking victims encounter a healthcare professional while they're being trafficked. That's critical. No other sector of our society sees these victims the same way we do. Law enforcement may encounter them on an occasion, but it's really us in healthcare that are going to see them most of the time. And so when you include all types, an easy number to remember is that when you include all types of trafficking, 2/3 will come into healthcare while they're being trafficked. And that puts an important responsibility on us as healthcare professionals to begin to identify them. So can you think of what major categories of indicators we might be looking for to see and begin to observe that a patient might be a victim of trafficking? Any thoughts?
Maybe signs of abuse, bruises and yeah.
Yep. Good. What else?
I was thinking maybe patients that like are never left alone by the people that come with them. So they're like always in the room with them, basically.
Very good. What else?
And when you're taking their history, then maybe they'll get more nervous, or they'll like look to the person they're with to validate their answers.
Yep. Good. All of those are very applicable. Well, here is the way. Go ahead.
I was once told that if someone comes in with like inappropriate clothing, like maybe they have sandals on and it's like in the middle of winter, 3
Yep.
inches of snow, so that way they can't run.
Yep. Yeah, or in certain major cities like Cincinnati in the middle of winter, you've got some girl that comes in and she's scantily dressed and it's what, 20 degrees outside. I mean, that's just weird, right? So those are all exactly right. So here is how I think of it. I put these categories in three major, or indicators in three major categories. There are indicators that someone else is controlling them. There is the strange red flags that you've already kind of mentioned, someone that comes in not really appropriately dressed, and then the physical indicators like the abuse that was already mentioned. So let me just go through a little bit of those. The one thing I want to point out, and this is critical for us in healthcare, that we have found that about 1/3 of children that are trafficked into sex are actually trafficked by family members. So it's important for us in healthcare that if we start seeing some of these indicators, that we don't say, wait a minute, I know this is the girl's mother, so she can't be being trafficked. That is not the case. So ignore the fact that they may actually be with their husband, or maybe with their mother or father or grandparent. If you see indicators of trafficking, they can still be trafficked, because unfortunately family members do that. And so as someone mentioned, they will control the conversation. They may even correct the patient. They may not allow them to answer certain questions, and that's just very strange in the healthcare profession. You would also see a lot of these things with domestic violence, of course, and initially domestic violence will look a lot like trafficking. Then, as somebody mentioned, they won't want to leave. And as an OBGYN for many years, I can tell you that husbands, especially, they're often brought into the first OB visit by their wives. They don't feel very comfortable being there. So I'll leave them in the room. And then when it comes time for the pelvic exam, I would typically say to the husband, do you want to leave and go out to the waiting room? And of course, he would, unless the wife said, no, you're going to definitely stay here. But that's a normal type of an interaction. In this kind of a scenario, it's the guy that's demanding to be there, even though the woman seems very uncomfortable about having him in there during the pelvic exam. So you need to watch for these interactions. So the other thing to do, again, is to watch their body language, because if they are being trafficked and this is a very controlling person that may be very violent, they aren't going to be able to say anything to us. So how can they communicate to us that things aren't the way they are supposed to be? Well, they'll do it through their body language of fear, of anger, maybe being very anxious. And, we may not at first be able to put a word on this because we're not thinking along these lines, but submission. They're submitting to this other person. That's obviously not very healthy. If they come from another country, they're not going to be in control of their passport or other ID documents, which is, again, the kind of a red flag. That's not normal. They won't be in control of their money. And there is an inherent shame that's found within trafficking. And so they typically will look down at the floor and not look directly into the eye of the healthcare professional. Now, when I was with Grace Haven, I would often talk to the girls, and there were so many of them that had encounters with healthcare. They would typically tell me a story that the trafficker would take them to an urgent care center to get them screened for sexually transmitted infections. And what they would do is they had such control over them that they wouldn't need to go into the healthcare facility with them. They would drop them off at the door and they would stay in the parking lot and they would tell the girl, you've got 45 minutes to get in and out and get done or I'm going to beat you. So that's their scenario. So when they come into healthcare, they're going to just be frequently texting because the trafficker is going to have a phone and they're going to want to know what's going on, where are you at now, what are you doing? They may even call them, and of course they'll want to have that phone with them constantly, even during the exam. They're obviously going to be in a hurry because they know they've got 45 minutes and they don't want to be beat. And so they want to get in and out, and so they'll be have this hurry and unwanted anxiety. So that picture is very common with minors. And so please remember that the degree of control, and it's really a form of trauma bonding, we call it, where they get emotionally bonded to the trafficker and they recognize the control they have, so they feel comfortable letting them come into healthcare all alone. There's some other weird, strange red flags that they may have. If they've come in to healthcare, urgent care, or emergency room right after a night working, they may have $1,000 in 20s and 50s. And it may not be you as the doctor that sees that, but the nurse does. And that's just really strange. Why would somebody have a roll of bills of $1,000 in their clothing? They may not know what city they're in. And this is assuming that they are neurologically oriented. And that's because they're frequently moved. There are circuits that these traffickers will take them through. And so they're moved from city to city, typically while they're asleep in the car. And so they lose track of what city they're in. And so they may ask, oh, by the way, what city is this? Well, that is a really weird question that ought to set off all kinds of alarm bells. They won't be able to give an address. They won't know how to get home because there really, in essence, is no home. And they are told by their trafficker to lie about their age, especially when they encounter law enforcement. And they typically do this in healthcare as well, which is very strange. We don't see that at all. Some other red flags, they won't have, again, the official documents. I usually talk, and when I talk to teachers, or if you're in a family practice setting eventually, and you know a family and they don't have a lot of means, and then this teenage girl comes along, she's 13, 14 years old, and suddenly she's got the latest version of the iPhone, and she's dressed to the hilt with all kinds of designer clothing. And you wonder, where in the world did she get the money for those things? That ought to set off alarm bells for you, because they will often be put through a stage where they're groomed by the trafficker and given all kinds of gifts like this. And so if they show up in your pediatric office or primary care office, you ought to begin asking a lot of questions. They may not be living with their parents. They won't be attending school either. They're going to be very poor historians, and that's because trauma messes with a person's timeline. I don't have time to get into that right now, but they truly lose a sense of when things happen. So a lot of our historical questions, as you're going to learn, have to do with, when did that symptom start? When did it get worse? When did this start? And they honestly can't answer those questions. So they get to be very frustrating to us in healthcare, because we look at these as very simple questions. Why can't they answer them? Well, you need to begin to realize there may be a reason for that. So the history can keep changing, become inconsistent. Pieces don't fit together in a clinical picture that you get used to, and you get the feeling you're not getting the whole story. So these are all things that can make you a little bit suspicious. And then finally, for instance, imagine somebody that's caught in a trafficking scenario and they have appendicitis. There are a lot of times they're not going to be able to get into the healthcare setting as early as we would think. And so they'll be held back. And so a lot of times you might be, and I used to work ER for many years, and I found that, a lot of us would get frustrated with them. Why didn't you come in when this right lower quadrant pain started and you were having such severe pain? Why did you wait 4 or 5 days? Well, maybe it's because somebody was keeping them from coming into the healthcare setting. So in terms of the actual physical indicators, and this is an advantage again we have in healthcare because we'll be doing physical exams and we can begin to see some of these things. In the international side, you might see malnutrition or unusual infections like TB. They will have lack of immunization because they have come into the country illegally. So they didn't go through the normal process and didn't have to prove that they were immunized. They'll have GI complaints because of the stress involved. They may be acting a little differently because of PTSD. There may be evidence of substance abuse, dental trauma, all kinds of physical trauma, and obviously multiple sexually transmitted infections. So those things should alert you that something is going on. A lot of it with domestic is very similar, except you don't have the problem with immunization generally or the unusual infections. And then there's one additional thing that we see, and that is tattoos. We don't see this internationally, but domestic traffickers like to tattoo their girls, and they see it as a form of branding. And these tattoos will typically be located on the same place on the body that the trafficker with all the girls under his control. And they'll typically use his street name. And one of the common names too is Daddy. So you might see that as well. So we can talk about that more if you have questions. So I want to move now to what are the barriers? What is it that you think might keep you from seeing these patients or these victims? Thoughts? Got someone pulling into my driveway. Well, for the sake of time, let me go through them. And these are important for you to understand. You need to, first of all, understand these victims are not going to come forward on their own generally. There are exceptions, they might, but most of them will not. Reason is because of shame and guilt. There's a shame of being controlled by another person, fear of a trafficker. These people are very violent. One of the girls that I had at Gracehaven, she told me the story when she was 14 years old. She was taken to the emergency room because the trafficker hit her and broke her jaw. And I said, he just hit you one time and he broke your jaw? And she said, yeah, but he was using brass knuckles. I mean, every time I remember this, I just get so angry. Just a grown man that hits a 14-year-old girl with brass knuckles. So obviously they're scared to death. So they're not going to say anything from that. Fear of deportation, obviously this applies to the internationals. And I don't understand this completely, but there are victims who would rather stay in the situation where they are because they've been told by the trafficker that if they were to come to somebody and tell them their situation, that they would be sent back home. That's not necessarily true. We can talk about that more if you want, but fear of deportation. And then lack of understanding of our system. By that, I mean that these people, especially internationals and even the US citizens, they don't necessarily understand that what's happening to them is illegal. They probably look at it that it's unfair, it's unjust, but to have them accept or understand that the person doing that to them can be put in jail for that is beyond what their understanding is. Even our kids don't understand that what's happening to them is an illegal activity. So they don't understand the system. So that's why they don't come forward. Then our ignorance of trafficking, we don't see this and put together. I remember before I understood trafficking and I was still practicing, I'll never forget a 16-year-old coming into my office. And one of my routine questions was to them, for obvious reasons, was how many sexual partners have you had? And her answer to me at age 16 was more than 500. I didn't know what to do with that answer. Now I would know, okay, she's been sexually exploited. It's no question. Then I could move right into talking, but I didn't have any understanding of this. And so we have this ignorance factor that really gets in the way. Emotional trauma bonding, again, I mentioned that briefly. It's similar to what we see in domestic violence. There is this trauma bond that gets the person emotionally connected to the abuser, and they don't really want to leave. They don't identify as victims. And then we have our bias as healthcare professionals. For instance, if we know somebody is in prostitution, a lot of times healthcare professionals will just treat them very differently and not recognize them as victims. So those are all barriers to identification. So for the sake of time, I'm going to move quickly through this so we can leave some time for questions. What should you do if you are in an ER and you see somebody who you suspect is a victim? Well, first, you need to have a response protocol in place. You don't want to do anything without a protocol. And this is what I recommend that people use. I was fortunate to partner with some other people in actually developing this toolkit back in 2018. It's put together by Heal Trafficking and Hope for Justice, the organization I was working for at the time. And it is a toolkit that takes any healthcare institution through all the steps that are necessary to develop a comprehensive response protocol. And so you'll probably be at institutions that do not have anything like this in place. Would be one way that you as a student or an extern could really have an impact on that hospital. You can make them aware of this resource, talk about the importance of creating this response protocol. I suspect that less than 10% of hospitals around the country have anything near what's necessary in terms of a response protocol. So what do you do if you do not have a protocol in place? My recommendations are that you simply treat the medical problems, that you do not try and intervene. That's going to be a mistake. It's going to create more damage, probably create greater harm to the victim because you don't have in place what you need to have in place. And then you want to report the cases to the National Human Trafficking Resource Center, and that's the number or the text number you can text. And if you happen to know, or the hospital happens to know, a trained law enforcement official, then you could report it to them after the patient leaves the office, urgent care center, emergency room visit, whatever you're at. And when I say trained law enforcement, not every local law enforcement official has been trained on trafficking, so they may not understand what to do. And again, they can inadvertently cause more damage than good. So I'm done about 10 minutes early. Happy to take any questions.
I actually have a question about international trafficking. So in the Middle East, it's common to have a domestic worker in your home, and those workers come from another country. And this, in some ways, the system sets it up because there's agencies that a family can go to get a domestic worker. There are contracts and there's some kind of pay. And we're talking maybe a couple hundred a month or something like that. And then long hours and off one day a week. So using, like, understanding kind of our understanding of trafficking, would you consider something like that trafficking if they've signed a contract but yet it's still exploitative in many ways, if that makes sense?
Yeah, that's a very good question. And certainly the potential for trafficking is great in that scenario. I would want whatever agency, whether it be non-governmental or governmental, to have the ability to interview those workers individually without the other person around and make sure they understand a couple of things. Can they leave their work situation whenever they want? In other words, they get frustrated and they say, I'm done, I'm out of here. Can they leave when they want? If the answer is yes, it's less likely to be trafficking. The other thing that that person should be able to do is to explain to them what their alternatives are, to make sure, do you understand that you could also go over here and make money by doing this? And in fact, it would be more money. And if the person says, yes, I understand that, but I like this, then again, it's not exploitive. But if they don't have clearly an ability to leave whenever they want, or they don't have an understanding of what their options are, then you're probably likely dealing with a near trafficking scenario. So that's the ideal of dealing with that particular situation.
Okay, thanks.
So I had a question. So a lot of us are second year med students and will be in clinics next year. And do you have any advice for like talking to someone that we maybe like suspect that they may be a victim? Like, should we get them in the room alone? And if we should, how do you recommend doing that? Like, do you recommend just telling the person that they're with that like it's usually protocol for us to like speak to our patients alone, or like how do you recommend us doing that?
Well, what you're asking there, Katie, is actually parts of the response protocol. In other words, one of the things that we ask and we tell hospitals and clinics to do in the process is to set up a procedure for separating the patient, and then what to do if that controlling person doesn't want to leave. So it's obviously, if the more they don't want to leave, the more suspicious I get. So I would go back and I would say, I would first of all investigate, does the hospital have a protocol in place? And if they have a response protocol in place, they should have something of how do we want to separate the patient. If they don't, I would be really hesitant to do anything, because you could suddenly set off alarm bells with the trafficker, or the trafficker may get suspicious if they've left the room and they come back. They may think that their victim has said something to you. They may get beaten later. So that's why it's so critical to have the protocol in place. So I think one of the things that you can do, and I've actually had some email interactions with students that have done this, is to bring it to the attention of the attending physician and say, hey, are you familiar with human trafficking? A lot are not. They probably have heard of it, but they don't know much about it. Hey, there's this resource out there through Hope for Justice and through Heal Trafficking that we need to really develop a protocol, because I think this particular person may be trafficked. So that the most I would feel comfortable recommending is getting as much demographic information. In other words, get what is their address? If they have a card, do we have a way of getting their license plate? And then turning that over to law enforcement, especially trained law enforcement afterwards. But don't try and do anything different in healthcare at all. That makes sense. Any other questions? Go ahead.
Go ahead. I just had a question. So what happens, say you have a protocol and things go appropriately, to maybe get them out of trafficking, what typically happens to the person then?
Well, it depends if they are a U.S. citizen or an international. If they're a U.S. citizen and you're fortunate to be in a city where there is a nonprofit or some form of agency that is designed to help that victim, they'll be sent to that agency. So like, for instance, if and we've dealt with Columbus Children's Hospital, and if they found a girl that was underage and was in trafficking and wanted out, they would be sent, first of all, to the juvenile court and adjudicated, and then sent to Grace Haven. We've had several girls that have come to us that way. If they're an international, it gets a little more complicated because they're not a U.S. citizen. And so then the FBI and Homeland Security gets involved, and they will investigate the case. And basically what happens is if the victim agrees to testify against the trafficker and to talk about in a legal case what happened to them, they will be granted a special visa and they can stay in the US. Unfortunately, a lot of them are fearful of doing that, and then the FBI is in this very awkward position where they recognize that someone is probably trafficked, but they can't prove it because the person is unwilling to testify. They can't go after the trafficker. So then in that particular instance, it's very frustrating. They probably will be sent back to their home country because there's very little else that can be done. So in the few minutes remaining, I would like to ask, in terms of I would genuinely like to hear from all of you. What is your environment like there in Cincinnati? Is there any increasing attack on conscience rights there for you as students? Are you hearing about that? Are you seeing that? Is there any pressure being put on you as Christian medical students? If so, I would really, really be interested to hear.
Dr. Barrows, can you rephrase the question and just kind of clarify what you mean for the people on the call?
Well, sure. You haven't gotten into clinical yet, but we have heard from around the country in other schools where students start getting into the clinical, for instance, and they're asked to go in and attend, certainly not do anything, but attend an abortion, for instance, or do something else that might impinge on their conscience. And if they don't do it, they are shamed and criticized for that. And so I'm very concerned about that as we move forward in this ongoing hostile environment. And I just didn't know whether any of you have experienced anything like that.
I
So-
will say, as a first
Go
year
ahead,
medical
Jordan.
student,
Go
I
ahead.
haven't experienced anything like that. I'm sorry. I was just saying, as a first year, I haven't experienced anything like that. But I haven't been in school for very long.
Yeah, kind of similarly to that. I don't think that I haven't either personally. But I feel like if I could put my like self in the shoes of someone who's a third year, I don't think that I think that our school is set up very well in that like if we feel that we're mistreated in any sort of way, that we can report that, and like that our beliefs and our like values are very, very respected by like the administration. That's kind of how I've seen it, but of course I haven't been in the clinic yet, but I do think that that would be considered mistreatment or some sort of like discrimination due to our like beliefs in some way, and I think that it would be addressed by the administration.
Well, that's good.
I could speak. I mean, I'm not a medical student. I'm CMDA staff, but I work with some other young adults, and we had an incident recently where a nursing student was. It was required for him to go to an abortion clinic and into one of the procedures, and he felt very uncomfortable about that, and he was very distressed about it, and had been praying and through he was really counseled from my boss, who that is a pastor here at the church where I'm also on staff, was to go to that, knowing not to go into the procedure per se, but to go to the clinic to fulfill the requirement, but to ask if he could sit in a different location, because his presence wasn't going to prevent the abortion. So from that side of it. But what was interesting is when he got there, the abortion clinic said, "We understand that some of you might not be comfortable with this, and so you're welcome to sit in this room and study," or something. And so what struck him was that the nursing school was forcing him more than the abortion clinic was forcing him, if that makes sense. And so, yeah.
Yeah, I mean, I have an interest in OB, so I've had a decent amount of like exposure with the faculty here, and they made a point to say like you will never have to do something that you don't feel comfortable with. If you feel like that's happening, let us know. So I feel like they did a good job of just like first and second years, like interested in maybe doing a residency or like in their third and fourth year rotations that shouldn't happen. If it does, it's an
I'm very, very glad to hear that, Michaela. I will tell you that from the national level, ACOG, American College of OBGYN, is, for reasons beyond my comprehension, is absolutely set on promoting abortion and knocking out any type of barriers, and also training professionals. So they have talked about ways of using federal funds and that type of thing to force people to do abortions. So it's been a concern at a national level. So I'm all that to say, I'm very glad that you have local people there that are obviously very tuned in to the needs of the conscience. And I would just say that you all have conscience rights. In other words, if you're ever asked as a student or a resident and to do something that you just goes against your conscience, we at CMDA on a national level are fighting for your right to exert that. And so anyway, that's my reason for asking, because I am, and all of us in the leadership of CMDA are very concerned about the ability. In fact, we're involved in a lawsuit, a federal lawsuit to protect your rights of conscience. That's actually in the Fifth Circuit right now. You won't have time to read about it, but we are at the federal level. We're fighting for your right to say no.
Can I ask a question related to all of that? I know that there's like the legal protection, but what sense do you get that students or attendings, they might have the right to refuse, but then they face, you know, maybe some challenges within their career, or they have, they have additional challenges that come with that. Maybe it, yeah. Does that make sense?
Yeah, I mean, I just heard, I'll give you a very tangible example. And I think this was an intern. It wasn't a student. It was an intern, first year. Well, it could have been a fourth year student somewhere that was never chosen to go into the operating room to kind of scrub in. And finally, the student asked the attending, "Why are you never asking? You're always asking these other and never me." And the answer was, "Well, these other students have agreed to help out with the abortions, and you have not. And so we're giving them first choice on this." So there are very tangible ways that our refusal can do that. And I should say that even though there are some legal protections, I was just at a meeting with an attorney that specializes in this the other day, and they said, frankly, they're not very good. And we're actually working with Alliance Defending Freedom, ADF. I don't know if you're familiar with that organization, but they are working hard to introduce in all 50 states legislation that would specifically protect the conscience rights of healthcare professionals. And we're helping them in that because it's so important to us. And also because at the federal level, there are lots of ways to get around the legal protections that have been put into place so far. And it's unlikely that we'll be able to get Congress to pass anything at a federal level that will be at all protective. In fact, it's highly unlikely we'll be able to do that without some kind of miracle. So there is some exposure, frankly, and that's one reason I wanted to ask. And I would just say it sounds like there in Cincinnati, you've got some really good people that really care about these things and are treating you well. And for those of you that are going into OBGYN, I would make it clear in your interview process, how does that hospital or that university treat those who have a conscious objection to abortion, because that'll be a huge part. it's fascinating to me. 85% of the members of ACOG are opposed to abortion. So only 15% are really in favor, but somehow the leadership of ACOG has taken control, and they're really doing all this. But enough on that. If you have any other questions about bioethical things and what we're doing at headquarters, I'm happy to answer. I got about 3 more minutes. All right. Well, I enjoyed being with all of you. I wish you the best in your professional endeavors, and hope that you stay members of CMDA as you pass through the various stages from student to resident to graduate. We need all of you to do that in lots of different ways. And so there are many ways you can plug in at the national level or locally too, if you so desire. So good to be with all of you today.
Thank you so much for your time, Dr. Barrows, and sharing with us.
Sure. Bye now.
Bye.
Thank you.